They are not pushed there by war or by famine, but by the simple act of trying to stay healthy. Almost 100 million people fall below the poverty line annually because they have to pay for health care. This is not just a statistic, it is a global crisis unfolding in quiet desperation across countless villages and cities. It represents a profound moral failure in our interconnected world. For these millions, a diagnosis is more than a health concern. It is a financial catastrophe waiting to happen, a trapdoor that can swallow entire families, leaving them with nothing. This devastating reality demonstrates the cruel intersection of health and wealth. When a family member gets sick, the costs of treatment can become an unbearable burden. In a small, sun-drenched village, far from any major city, a young mother named Amina woke to the sound of her child's labored breathing. The boy's fever had been rising for 2 days, and a deep, rattling cough had settled in his chest. Fear clutched at her heart. The local clinic, a small concrete building staffed by a single nurse, was a long walk away. She knew it would demand a fee for consultation and for any medicine she might need. The few coins she had saved were not nearly enough to cover the cost of care, a fact that weighed on her as heavily as her son's illness. With no other choice, Amina made a decision that countless parents in her position are forced to make. She sold the family's 2 goats, their primary source of milk and a vital asset. The money from the sale was just enough to pay for the clinic visit and the initial round of medicine.
"I had to do it," she would later say, her voice quiet but firm. What else could a mother do when her child cannot breathe?
Her words echo the silent desperation of millions who must sacrifice their future security for immediate survival, hoping that one desperate gamble will be enough. But the medicine did not work as quickly as they had hoped. Her son's condition worsened, and the clinic nurse said he needed stronger antibiotics, which were more expensive. The family's small savings were already gone. With a heavy heart, Amina and her husband sold a small parcel of their farmland, a piece of earth that had been in their family for generations. They used the money to buy the new drugs, praying this would finally bring healing. For weeks, the family ate less, their meals shrinking as their resources vanished. The loss of their land and livestock was a devastating blow. Amina's story is not an isolated tragedy. It is a common narrative repeated daily across the globe, from the rural plains of Africa to the mountain villages of Asia and the urban slums of Latin America. The primary driver of this crisis is a concept known as out-of-pocket spending. This is when people must pay for health services directly from their own funds at the moment they need care, with no help from government subsidies or insurance. In wealthy, high-income nations, these direct payments make up a relatively small portion of total health spending. National health systems, employer-sponsored insurance, other social protection schemes. This creates a crucial buffer that protects individuals and families from the full financial impact of getting sick. Ensuring a medical emergency does not automatically become a financial one. In many low- and middle-income countries, however, the situation is tragically reversed. Out-of-pocket payments represent a much larger share of health financing, sometimes accounting for over half of all spending in the sector. Governments may lack the tax base or the political will to fund a comprehensive public health system, and formal insurance is often inaccessible, so the burden falls on individuals. See a doctor, get a lab test, buy medicine. They are often presented with a bill that must be paid on the spot. This reliance on direct payments creates a formidable barrier to care. For those living on just a few dollars a day, even a small fee for a consultation can be prohibitively expensive. Consequently, many people delay or forgo seeking medical help altogether, allowing preventable or treatable conditions to become more severe and costly. A simple infection that could have been cured with a cheap course of antibiotics can escalate into a life-threatening illness. This system effectively rations healthcare based on the ability to pay, leaving the poorest and sickest with the least access to services. The consequences are devastating for both health and economic well-being. Do you sell the land that feeds your family to pay for your child's medicine? Do you pull your children from school to cover the cost of a hospital stay? The gap between those who have access to quality health care and those who do not is not shrinking. In many ways, it is widening. This growing divide is fueled by a constellation of economic forces, political forces, social forces. High-income countries spend, on average, thousands of dollars per person on health each year. Advanced hospitals, well-trained medical staff, comprehensive health services. In contrast, many low-income nations can only afford to spend a few dozen dollars per person, leaving their health systems chronically underfunded, understaffed, and ill-equipped. External debt, structural adjustment policies, and trade agreements pressure budgets away from health. Brain drain leaves shortages of doctors, nurses, and essential health workers. Rapid innovation, new technologies, diagnostics, breakthrough medicines brings hope, but at exorbitant prices. When a family faces a major health expense, the immediate cost is only the beginning of their financial turmoil. The true impact is a devastating ripple effect that can destabilize every aspect of their lives for years to come. A single surgery or a prolonged illness can easily cost more than a family's entire annual income. To cover such an expense, the first assets to be sold are often those that generate income: livestock, farming equipment, a small shop's inventory. This immediately cripples the family's ability to earn a living. One of the most tragic consequences is the removal of children from school. Malnutrition and untreated illness create a vicious feedback loop of sickness and destitution. High-interest loans can spiral into debt bondage, all because someone got sick. World Health Organization, World Bank, they track this phenomenon, catastrophic health expenditure, and estimate nearly 100 million people pushed into extreme poverty each year. The fact that millions are impoverished by healthcare costs is not an accident. It is the direct result of systemic failures in how we finance and deliver health services. A primary cause is insufficient public funding for health in low and middle-income countries. Budgets often prioritize defense or infrastructure instead. Chronic underinvestment means too few clinics, too few salaried health workers, and not enough essential medicines. With gaps in public provision, people rely on fragmented, often unregulated private care operating for profit. Fees for every service, often unaffordable for the average person. Market-based healthcare excludes the poor. Ability to pay, not medical need, decides who gets care. Past policies introduced user fees and cut public spending, sharply reducing access for the poor. Patents keep generics off the market, setting high prices that keep life-saving drugs out of reach. And where political will is weak, the marginalized, without voice or power, are overlooked, and the system continues to fail those who need it most. Despite the scale of the problem, proven and powerful solutions exist. The single most effective strategy to protect people from catastrophic health costs is the implementation of universal health coverage. Everyone should have access to the quality health services they need without suffering financial hardship as a result. Move away from out-of-pocket at the point of care toward prepayment and risk pooling through taxes or social health insurance. When costs are shared across the population, no single family bears the full burden. Thailand's 30 Baht scheme provided comprehensive care for a nominal co-payment, reducing out-of-pocket spending and improving access. Rwanda's community-based schemes helped drive a steep decline in child mortality. UHC requires political commitment, increased public financing, reliable medicines, and a paid, trained workforce. A healthy population is more productive, and protecting families strengthens the economy. De-link healthcare from personal wealth and break the cycle of sickness and poverty. While national policies like universal health coverage are essential, some of the most impactful solutions are being pioneered at the local level, on the front lines of care. Community health workers, often women, receive basic medical training to provide essential services where people live, bridging formal systems and remote populations. They manage childhood illness, provide vaccines, screen for malnutrition, and ensure prenatal care. Trusted, local, and culturally fluent, they reach the most vulnerable households. Mobile phones enable telemedicine and mHealth at low cost. Remote consults save time and money. Portable diagnostics speed up treatment at the doorstep. Community-based health insurance pools risk and builds trust. Combine CHW's technology and local financing to build resilient, equitable systems from the ground up, making care truly affordable for everyone. The human cost of unaffordable healthcare is immense and unacceptable. It is measured in the children who die from easily treatable diseases, the mothers who do not survive childbirth for lack of a skilled attendant, and the families who lose everything they own to pay a medical bill. This is more than a failure of economics. It is a failure of empathy and a betrayal of our shared humanity. The story of Amina, forced to sell her family's future to save her child's life, is a reality we must refuse to accept. We have the knowledge, the resources, and the proven solutions to build a different world. Governments must make health a priority and move decisively toward universal coverage. Global institutions must back fair pricing and long-term system building. Change comes from the top and from the front lines and citizens who demand accountability. We must listen, stand in solidarity, and choose to close the gap now.
Health is not a privilege. It's a fundamental human right, a core principle underpinning the concept of universal health coverage. Yet today, more than half of the world's population still lacks access to essential health services, facing significant and often insurmountable barriers. This global health gap is a complex issue, driven by pervasive poverty, challenging geographical isolation, and severely inadequate infrastructure. The dream of healthcare for all remains an unfinished journey, but it is certainly not an impossible goal to achieve. Disparities in healthcare access exist not only between different countries, but also profoundly within them, disproportionately affecting vulnerable populations. An inadequate health workforce and insufficient medical facilities further exacerbate this gap, leaving millions without necessary care. However, several nations offer valuable lessons in bridging this gap, demonstrating successful models of universal health coverage that we can learn from. Countries like Taiwan, with its universal national health insurance system, provide comprehensive coverage, short waiting times, and affordable costs for all citizens. South Korea blends public healthcare with private delivery, excelling in advanced technology, patient safety, and remarkably low costs. Australia's well-regarded system emphasizes preventative care, while Norway delivers high-quality healthcare through a strong public system funded by taxes. The United Kingdom's National Health Service, or NHS, is renowned worldwide for providing free healthcare to its residents and citizens at the point of use. A crucial strategy involves strengthening primary and community care, acting as the essential first point of contact for all healthcare needs. This includes vital services like vaccinations, comprehensive screenings, and the effective management of chronic diseases, all delivered close to home. Investing in these local services is key to reaching underserved populations and ensuring equitable access to essential health services for everyone. Technology also plays a vital role, profoundly transforming healthcare through innovations that enhance access and efficiency. Telemedicine, for instance, enables remote consultations, diagnoses, and treatment, effectively expanding access for those in remote locations or with limited mobility. Artificial intelligence improves diagnostic accuracy and personalizes treatment plans, while wearable devices monitor health conditions in real time, providing valuable data. Even drones are being utilized to deliver essential medicines and supplies to remote and hard-to-reach areas, expanding access significantly. Electronic health records streamline patient data management, improving care coordination and enhancing overall efficiency within the healthcare system. Global health initiatives are humanitarian efforts that raise and disperse funds for infectious diseases, immunizations, and strengthening health systems in developing countries. Recognizing that factors like education, income, and living conditions significantly impact health, addressing these social determinants is crucial for equitable outcomes. Achieving healthcare for all demands global solidarity and robust partnerships among governments, international organizations, NGOs, and the private sector. These collaborations are essential for mobilizing resources, sharing vital knowledge, and implementing effective strategies worldwide to build stronger health systems. Healthcare for all is not merely a dream. It is our shared responsibility, a collective commitment to human well-being and dignity. By working together with unwavering dedication and innovative solutions, we can truly make the promise of universal healthcare a reality for everyone. This ensures that every individual, regardless of their circumstances, has the opportunity to live a healthy and fulfilling life.
Hi there, I'm Misara. Well, I guess you could call me Peaceism. Yeah, peace works. Let me show you something important. See these people? They're all struggling with healthcare. It's tough out there. But what if I told you there's a way to change all this? Enter World Peace Development Holdings Limited. They've got this amazing idea called the Peaceism ecosystem. It's all about bringing people together, you know? Healthcare for everyone. Watch this. See how everything's connecting? Now look, people are healthier, happier, and more peaceful. Cool, right? Want to be part of this change? Join us at the Healthcare for All Expo. Together, we're building a sustainable future. How's that for world peace? Remember, a healthy world is a peaceful world. See you soon.
For far too long, we have operated under a flawed assumption. We have treated the mind and the body as two separate, unrelated entities. We visit one doctor for a persistent cough, and another, if we dare, for a persistent feeling of sadness. This division is not rooted in human biology, but in the history of our health systems. It is an artificial divide that has created profound barriers to receiving good, compassionate care. It forces people to navigate a fragmented system, often at a time when they feel most vulnerable. This separation is inefficient, and it is failing millions of people around the world every single day. The truth is that our health is a single, interconnected state of being. You cannot be truly physically well if you are not mentally well, and vice versa. It means bringing mental health care into the spaces where people already go for their physical health needs, like primary care clinics, community health centers. It means treating the whole person, not just a collection of symptoms. This approach makes care more accessible, more effective, and deeply respectful of the human experience. It is the future of medicine. Imagine a world where discussing your mood with your family doctor is as normal as checking your blood pressure. This is the promise of integrated care. When mental health support is woven into the fabric of routine health care, it becomes just another part of staying healthy. This normalization is crucial because it helps people get help sooner, before a small problem becomes a crisis. It acknowledges the undeniable reality that our emotional well-being is fundamental to our overall health. Therefore, our mission must be to dismantle this artificial wall between mind and body. The cost of inaction is too high, measured in prolonged suffering, worsened chronic diseases, and lives diminished by preventable distress. By embracing a model of integrated care, we are not just redesigning health services. We are promoting a more humane and effective way of caring for one another. This shift is not a distant dream, but a practical and achievable goal. It begins with the understanding that mental health is not a luxury, but a fundamental component of all healthcare, for all people, everywhere. Our bodies and minds are in constant conversation. This is not a philosophical concept. It is a biological reality. Think about a time you felt intense stress or anxiety. You might have experienced a racing heart, a knot in your stomach, a tension headache. These are not imaginary symptoms. They are physical manifestations of your emotional state. The brain, through a complex network of hormones and nerve signals, directly influences the functioning of every organ in your body. When the mind is under prolonged distress, the body bears the burden, often in silent and destructive ways. Consider the impact of chronic stress. When we are consistently worried or overwhelmed, our bodies are flooded with hormones like cortisol. In the short term, this response helps us manage threats. But over weeks, months, and years, elevated cortisol can weaken the immune system, making us more susceptible to infections. It can raise blood pressure, increasing the risk of heart disease, stroke. It can disrupt our digestion, leading to issues like irritable bowel syndrome. This cascade of physical consequences shows that ignoring our mental health is a direct threat to our physical health. The connection flows in the other direction as well. Living with a chronic physical illness such as diabetes, arthritis, or cancer is an immense psychological challenge. The daily management of symptoms, the uncertainty about the future, and the physical pain can understandably lead to feelings of sadness, anxiety, or hopelessness. It is no surprise that people with long-term health conditions have a much higher rate of depression than the general population. When this depression goes untreated, it can make it harder to manage the physical illness, creating a vicious cycle of declining health. This intimate link means that we cannot effectively treat one without considering the other. A doctor trying to help a patient control their high blood pressure will have limited success if the patient's untreated anxiety is keeping their stress hormones elevated. Similarly, a person struggling with depression may find it difficult to muster the energy to exercise or eat nutritious food, further impacting their physical well-being. Recognizing this two-way street is the first and most critical step toward providing care that truly heals the whole person, mind and body together. Many people arrive at a primary care clinic with physical complaints that are difficult to explain. Persistent fatigue that sleep does not fix, vague aches and pains that move around the body, stubborn digestive issues with no clear cause. Doctors may run a series of tests, blood work, scans, examinations, only to find that everything appears normal. This can be frustrating for both the patient and the provider. Often, these mysterious physical symptoms are the body's way of expressing emotional distress. A person who is not comfortable saying, "I feel deeply sad," might instead say, "I am tired all the time." Someone grappling with anxiety might describe a constant feeling of being unwell or having a racing heart. In many cultures, it is more acceptable to talk about a physical ailment than an emotional one. The body becomes the voice for a mind that is struggling to speak. Stigma is one of the most powerful and destructive forces in healthcare. It is the shadow of shame, fear, and misunderstanding that surrounds mental illness. This shadow creates a wall of silence, preventing countless people from seeking the help they need and deserve. People worry about being judged by their family, friends, or co-workers. They fear being labeled as weak, crazy, or unstable. In many communities, these labels can lead to social rejection, discrimination in housing and employment, and a profound sense of isolation. The impact of stigma is devastatingly practical. People suffer in silence, hide postpartum depression, or delay help for years. Systems can reinforce stigma when services are far away or hidden, with long waits and daunting referrals. Integrated care is a powerful antidote. When mental health pros are part of the primary care team and doctors routinely ask about well-being, it sends the message that mental health is simply health. Integrated care is not a single rigid formula. It is a flexible approach that can be adapted to different settings and resources. One of the most effective and widely studied models is the collaborative care model. In this setup, a primary care team, a doctor and nurse, works hand in hand with a behavioral health care manager and a consulting psychiatrist. The care manager, often a social worker or psychologist, meets with patients in the clinic, provides brief counseling, and tracks progress with simple tools. They consult regularly with the psychiatrist to adjust the plan, in close communication with the primary care doctor. Another approach embeds support in community settings, where people live, work, and gather. Trusted workers provide psychological first aid, teach basic coping skills, and connect people to more specialized care. Digital stepped care offers scalable first steps, guided apps, online programs, brief phone support, with step-up pathways to therapy or intensive care as needed. The common thread among these models is teamwork and communication. They break down the silos that have traditionally kept physical and mental health providers apart. Information is shared, care plans are coordinated, and the patient is always at the center. The goal is a no-wrong-door system where any entry leads to identifying and addressing both physical and mental health needs. This coordinated, team-based approach is the blueprint for a more effective, efficient, and compassionate system of care for all. While systemic change is crucial, there are powerful steps you can take to begin integrating your own mind-body care. Start the conversation. Next visit, be prepared to talk about your whole health. Reflect on emotions, sleep, energy, and mood. Choose one trusted health worker and share it. Simply saying, "I've been feeling very stressed lately," can be the key that unlocks better care. Second, build a personal toolkit for managing stress and improving emotional well-being. These do not need to be complicated or time-consuming. Start with deep breathing 5 minutes daily. Inhale 4, hold 4, exhale 6. This simple exercise can calm your nervous system. Visual. Simple infographic. Deep breathing, regular sleep schedule, talking to a friend, going for a short walk. Focus on a regular sleep routine. Consistent bed and wake times. Small, consistent habits beat big, sporadic efforts. Third, do not underestimate connection. Stigma thrives in isolation, and connection is its natural enemy. Seek a support group in your community or a moderated online forum. Sharing your story reduces shame and loneliness. Finally, be proactive in health planning, especially with chronic illness. Ask your team to include mental health support. By advocating for whole-person care, you improve outcomes and help educate providers about integration. For health systems and providers, the journey toward integration can begin with small, manageable steps that have an outsized impact. First, invest in training for primary care teams, nurses, community health workers, doctors. They do not need to become psychiatrists. Equip them with short, practical training to screen common conditions and ask compassionate questions. Teach brief, evidence-based psychological interventions. Second, add a dedicated mental health worker on site. Warm handoffs, brief therapy, coping skills, and regular follow-up transform access and reduce stigma. Third, use simple screening tools systematically, 2 or 9 questions, integrated into the electronic record to track progress over time. Finally, build clear, fast, supportive referral pathways with local partners, shared records, and dedicated lines so patients feel supported end-to-end. To understand the real-world impact of integrated care, consider the story of Maria. She's 54, living with type 2 diabetes for nearly a decade. She kept up with clinic visits, but blood sugar stayed high. She felt profound exhaustion and overwhelming demands of monitoring food, checking blood, and taking medication. A quiet sadness settled in. During a routine checkup, Sarah tried a different approach. After reviewing logs, she asked, "Maria, I know managing diabetes is a lot of work. Beyond the numbers, how have you been feeling in yourself lately?" Maria hesitated, then shared poor sleep, lost interest in hobbies, and feeling hopeless, believing it was weakness. Because the clinic used integrated care, Sarah reframed it as a health issue and introduced David, who met Maria the same day, taught a simple breathing technique. Over 3 months, 4 brief follow-ups and small goals, daily walks, reconnecting, while the team coordinated care. Maria's mood lifted, diabetes got easier, and readings improved. She later said, "For the first time, I felt like someone saw all of me, not just my disease." The evidence is clear. The moral imperative is undeniable. The time has come to end the false separation of mental and physical health. Integrating care is not radical. It is practical, humane, and cost-effective. Our minds and bodies are one. Earlier detection, improved outcomes for chronic diseases, reduced stigma, greater patient satisfaction, more sustainable health systems. This does not require an overnight overhaul. Small, deliberate actions build momentum. 1 clinic pilot, 1 university adding training, 1 community leader championing awareness. A story that can be shared, a model that can be replicated, a source of inspiration for others. Movements are built step by practical step, from the ground up. The path forward requires a shared commitment from all of us. If you are seeking care, be brave. Start a conversation about your emotional well-being. Ask for the whole person care you deserve. If you are a provider, be a champion. Learn one skill. Try one screening tool. Advocate for adding a counselor. Together, we can build systems that are smarter and kinder. No one should suffer in silence. Seeking help for emotional distress should be as normal as getting a cast for a broken arm. Let's commit to taking one action this week. Talk to one person. Share one story. Start one new practice. Let's begin bridging the divide and building a future where every person receives whole, compassionate care and can truly thrive. This is integrated care. You are not alone.